Good evening. Today I am going to talk to you about renal stones. Before I talk to you about renal stones, we should know a little bit of the anatomy of the kidney. The function of the kidney, there are two kidneys which are retroperitoneal structures lying in the lumbar region, retroperitoneally. The kidneys are bean shaped. You see, this is like a bean. Mostly, this is the right kidney, this is the left kidney. The right kidney is lower as compared to the left kidney, and both the kidneys have got a suprarenal gland at the upper pole. The kidneys, the main function is excretory, the excretion of water and waste products. They are filtered out, and through the ureter, this goes and joins the urinary bladder here. This is the urinary bladder, which is a pelvic organ, a midline structure. Now, you see here, the kidney has got upper pole, the lower pole, there is a hilum, and from the hilum emerges out the right renal vein on the right side and left renal vein on the left side. You see the left renal vein is longer as compared to the right renal vein, because inferior vena cava is lying on the left side, whereas the aorta lies on the left side, and therefore the left renal artery is shorter as compared to the right renal artery. And from the hilum, the pelvis of the kidney emerges, the pelvis number 1, and this continues as ureter, which joins the urinary bladder below. Kidneys are 11 centimeter long in adults, about 6 centimeters wide and 3 centimeters thick from anterior posterior direction. And kidneys, both the kidneys have got a cortex outside covered by a renal capsule, and the fat which is called fascia, which is called Girota's fascia. Kindly read, you will come to know it better. What I am talking about, you can revise. It is outer cortex and inner medulla. The cortex has got, renal corpuscle, the glomerulus, and medulla has got pyramids, which are somewhere around 9 to 14 number. And each kidney has got the pelvis, and they have got the upper calyx, the middle calyx, and the lower calyx. I will try to show you the diagram and snap of the calyx also. So, the function of kidney is not only the excretory function, but it has got endocrine function also. The renin is secreted here. It has got, and it also secretes erythropoietin, which is needed for hematopoiesis also, for the production of RBC in the bone marrow. Now, as you see here in this diagram, the kidney is lying on the posterior abdominal wall. The medial most wall is this one, over which the kidney lies. It's called psoas major, and just outside the psoas major is another muscle which is called quadratus lumborum, and lateral most muscle on which the kidneys lies is called transverse abdominis. And if you look anteriorly, the first structure which comes across when we go anteriorly, in the hilum you find there is a renal vein, and thereafter comes the renal artery, and posterior to that is the pelvis of the kidney. So, whenever you want to operate upon a renal stone by open surgery, we have to approach posteriorly, and it is impossible, it is not appropriate to approach the kidney or the stone in the pelvis, if any, from the anterior side, because you come across the renal vein and the artery. The kidney is, as I already have mentioned, that it's 11 centimeter long, 6 centimeters wide, and 3 centimeters thick, and it has got a outer convex border, and the medial is the concave border, and just posterior to 5 mm behind the convex border you find a line which is called Brodus line, which separates the anterior segments of the arteries from the posterior segments. Now, I will show you the few more snaps before I go to the symptomatology, which will clear some of your doubts, and you can take and seek the help of books to refresh and upgrade your knowledge. Kidney has got, as this snap shows us, there is outer renal capsule, and just medial to renal capsule inside the kidney is this is the cortex, and then comes your medulla. And this, this kind of a structure here, this kind of which I'm trying to make diametrically, which is not shown, is called pyramid, and the tip of the pyramid opens into the renal papilla. So therefore, before the urine is excreted into this part here, it comes through the minor calyx into the major calyx. So there are three major calyx: the upper one, the middle one, and the lower one. The upper calyx has got three minor calyxes, and the middle one has got two, and the lower calyx also has two minor calyx. So therefore, urine is secreted into these calyxes, and from here it comes into the pelvis, and down the ureter goes into the bladder. So therefore, you can ascertain by certain investigation whenever something goes wrong with the kidney, or there's some disease which is affecting it. Here again I am showing you a snap which will reveal what are the kind of symptomatology a patient will come. And one of the main features of renal disorders is the passage of blood in the urine, which is called hematuria, which may be gross, means on mildly, well, you see the color of the urine, it is reddish in color, whereas the normal urine is yellowish. So therefore, there are so many causes of hematuria, that passage of blood in the urine, which may not be visible to the gross eye, but on microscope also you can see the RBCs in the urine. Then it is called microscopic hematuria. If you can only see the blood in the urine through the microscope, it is called microscopic hematuria. And the books mentioned less than 3 RBCs are not significant. However, 3 or more than 3 RBCs means yes, it qualifies to be called microscopic hematuria. There we have illustrated, the book has mentioned here, there's so many causes which can cause hematuria, and one of the causes of hematuria is, as you see, the pre-renal causes, and there are diseases which are mentioned here like purpura, sickle cell trait, anticoagulants, persons, heart patients who are taking anticoagulants, or antiplatelets and things like that. And there may be locally involvement of the kidney because of infarction or injury. When there is a trauma to the kidney, it will present. There is a contusion and laceration, it will present hematuria, the gross hematuria. And in tuberculosis also a person may have hematuria. Then of course, one of the causes of hematuria and pain of renal origin is because of the stones. It may be lying in the kidney substance itself, kidney proper, or it may be lying in the pelvis or something like that. Then stone may be there in the urine, and then of course there are certain reasons of hematuria, like involvement of the urinary bladder. Kidney may be having renal cell carcinoma, which presents as painless hematuria. Person will come to you, blood is coming out, sir, खून निकल रहा है पेशाब में, लेकिन दर्द तो नहीं है. So there is a strong possibility of renal cell carcinoma, which is called hypernephroma, because it may be found on the upper or lower pole of the kidney. And another causes of hematuria of bladder origin are maybe infections like tuberculosis or cystitis. Again, there may be injury. There is some schistosomiasis, liver, this thing, flukes, liver flukes or something like that, which are generally found in Middle East. Then a prostatic enlargement, if the carcinoma of the prostate is there, or benign enlargement of the prostate is there, or there is a bladder stone, and sometimes it is mentioned jogger's hematuria, persons who do quite severe exercise for a long time, they also may get hematuria. Then of course finally there may be some pathology like malignancy of the urethra, which may present as hematuria. This is a snap. We'll talk about these investigations later. This is an investigation which is called intravenous urogram, that is called excretory renography, thereby meaning that it visualizes the intravenous urogram is a kind of a static presentation of dynamic events. The intravenous urogram is still lingering on the sites that we have got so many modern investigations to ascertain the pathology of kidneys, but still we need, this is still mentioned in the books. Here you don't see the kidney proper, but however you will, very, if you have a good amount of this thing, there is a little, we inject a dye into the vein which is tagged to iodine, which is radio opaque and excreted in the kidney. So therefore you can find out the anatomy and any abnormality of the calyces, major calyx or minor calyx in the excretion urogram. Now here in this is an intravenous urogram in which urographin has been given, which is injected into the vein, and before you inject it, I'll talk to you later on, you have to do a little sensitivity test also. But suffice to say here that you find here the pelvis of the kidney, you find here the ureter, it's a normal. There are peristaltic waves also in the ureter, so that means the diameter of the ureter keeps on altering according to peristaltic wave. But here you find there is a upper calyx and the normal calyceal cupping also you find. There is the upper calyx, there is the middle calyx and the lower calyx, and you find a radiolucent shadow here. Can you see it? It is not radio opaque. Stones are generally radio opaque. We'll discuss it out later on, but there is a radiolucency here, radiolucency. Therefore, it must be a stone which is radiolucent. Also, now I want to draw your attention. This is a snap of the CT. What do you find here? This is the left kidney here, which is normal. Okay. What right kidney you find is enlarged as compared to the left kidney. This is the lumbar vertebra here, and you find the right kidney is enlarged and there is a tumor here. This is computed tomography, and such a large structure which is rounded, you find hypodense shadows also here. It denotes that there is some mass and possibility it may be renal cell carcinoma, which has to be confirmed by fine needle aspiration cytology. In this snap you find there is a normal intravenous urogram. The pelvis of the kidney, the major and minor calyces, they are visualized, and you see the calyces here show minor cupping. This is a cupping, it's cup shaped like this. Clubbing means when they are, there is obstruction to the outflow of the kidney and the calyces are extended, so this normal cupping is lost. Here you find that in the pelvis you find the bladder also and the ureter coming. You're taking a course at ischial spine, the regional ischial spine medially, and opening into the urinary bladder, the intramural portion, which is called intramural portion of the ureter, and the urine comes out through the ureteric orifices. Another investigation I will tell you is the ultrasound. It is a very important investigation. Ultrasound for the kidney. It can be done for even bladder, liver, spleen, and for the ovary and uterus, etc. Now here in ultrasound, what you find, this is a normal kidney. You find in this there is cortex and there is medulla, and you can see the shadow of pelvis also. Ultrasound is very important and is real time. It doesn't take a lot of time. It's patient undergoes investigation of ultrasound and the diagnosis, or whether the kidney is normal or it has got some stones or there's some kind of a malignancy or the cyst. Patient comes to know about it on the real time basis there and then itself. Now let me talk to you about the symptomatology of kidney involvement. The main important events in renal pathology is, number one, which I have already discussed with you, is hematuria. Hematuria means there is blood in the urine, and there are various causes which I have already told you. The most important cause in our practices are the renal stones. I'll discuss with you type of the renal stones and investigations we do for this. So hematuria is caused by diverse reasons. The most important reason commonly which is seen are the hematuria because of the renal stones. And which type of stones may cause hematuria? Mainly these are calcium oxalate stones, which are hard, irregular, and they are spiky. And they try, when there is a movement of the renal stone, it may damage the urothelium, and as a result, there may be hematuria. So when a person has got hematuria, you can see it grossly if there is large amount of blood which is coming in the urine, or it may be microscopic hematuria. Otherwise, we have got various tests to detect it, like microscopy. The next important symptom of kidney disorder is renal pain. A person says having renal stones. The patient will be having pain in the renal angle. The renal angle is, posteriorly, it is the angle between the 12th rib. You see me, that rib comes like this, floating rib, 12th rib here, and between the sacrospinous muscles. So behind, posteriorly, in renal angle, there is pain. It is a nagging type of pain, dilating type of a pain, unpleasant pain, and sometimes this pain, renal involvement, they may be lying anteriorly in the lumbar region also. But in case a person has got a stone and it's moving, the renal pain may be a severe pain, and the stone, say a small size calcium oxalate stone, the pain sometimes radiates from loin to groin. It may go into the genitalia or the scrotum or the medial aspect of the thigh, and in females it may go down into the female external genital organs. The pain of kidney, if it is painless and person has got hematuria, as I've already told you, it may be because of malignancy. I will not go in much into details. The other symptoms which are associated with kidney involvement are the infections. The kidney may be infected because of diverse reasons. There may be pyelonephritis. Pyelonephritis means there is involvement of renal parenchyma, and the pain may be because of because of the stone, which is a very sharp pain. And in this kind of scenario where a person has got infection of the kidney, it may be glomerulonephritis, it may be pyelonephritis, or it may be pain just because of which has come through the hematogenous route or the ascending infection. There are so many other causes of infection. Once a person has got infection, person may be associated with these complaints. Patient may say that he has got low-grade fever, there is a pain, and there is an increased frequency of micturition. If the infection goes down, lower urinary tract. There may be involvement of the bladder, urinary bladder. Once urinary bladder is involved, then infection of urinary bladder is called cystitis. And the cause of cystitis is basically, there may be an elderly person, there is obstruction to the outflow of urine, obstructed uropathy. There is stasis, and stasis is the cause of infection. And when urinary bladder is infected, the patient will have pain in the suprapubic region, dilating pain. There may be pain just because a person has got enlarged prostate, there is a retention of the urine, there is acute retention of the urine, patient has got a kind of a intense desire to pass urine, but he is not able to pass urine because the prostate is enlarged, and it has got various mechanisms why it causes acute retention of the urine. That is not appropriate at this moment to discuss the prostatic enlargement, things like that. And the pain, lies in the suprapubic part. And if there is acute retention in the urine, you have a palpable tender lump in the hypogastrium. And person may have other symptoms associated with it. I'll basically try to remember 3 of the things whereas bladder is not functioning properly, because since we are discussing the kidney, so therefore it becomes little appropriate to discuss bladder dysfunction. Sometimes in elderly people, detrusor, the muscles of the urinary bladder, may contract inappropriately, and the premature contraction of the detrusor muscle results in what you call urgency type of a thing. A patient may pass urine, an elderly person. So therefore, at times the bladder is enlarged because of prostatic enlargement, and patient, his desire to pass urine comes down, and he has got chronic retention. There's a, what you call detrusors get dilated hypertrophy, and patient is not able to pass adequate amount of urine. Now, he doesn't have that kind of intense desire also. Then comes your hesitancy. Hesitancy means when a person wants to pass urine, prostate is enlarged, he is unable to initiate the act of micturition, or there may be frequency of micturition. Frequency of micturition means that he goes to void himself to pass urine, and he is still not satisfied. There is feeling of incomplete voiding of the urine. He wants to pass again, so he is going up to the washroom, coming back again, going, and things like that. And there may be burning micturition. There may be fogging of the stream. There are multiple streams coming out. There's a delayed emptying. He is spending quite a lot of time in the washroom. So basically, hesitancy is there, feeling of incomplete voiding is there. There's a frequency of micturition is there. There is a thinning of the stream, and the person may have this thing also, incontinence, dribbling the urine. He coughs and he wets himself. So anyway, these are besides the point. Now let us see, for a person having pathology of kidney origin, what are the investigations we should do. Person comes to you with a pain in the renal angle, or a pain which radiates from loin to groin, and patient has low-grade fever, he has got a burning micturition. So various type of investigations focusing on kidney is number one. The age-old investigation which comes to our mind is X-ray. X-ray of the abdomen. X-ray of the abdomen will tell you if the patient is expired. We do X-ray of the abdomen for kidneys, for ureter, and the bladder. X-ray will also tell you the involvement of the bones, if there is any. The person may have malignancy of the prostate, so probably METs you may be able to see. X-ray of the abdomen will also tell you the cause of pain. Maybe person might be having perforated uterine ulcer, so there will be leak of gas, and person, if you do the X-ray abdomen in erect posture, what you find is gas under the domes or diaphragm. That means gas has come from somewhere, from the hollow viscus, and gas ascends up, so it gets localized in the both domes of diaphragm, mainly on the right side, if it is perforated uterine ulcer. So X-ray KUV will also tell you of any radio-opaque shadow in the kidney, because X-rays, they absorb the radiation, and so therefore if it is a stone, mostly you will have a really opaque shadow anywhere within the kidney shadow. You may locate a stone in the ureter also, you may locate a stone in the bladder also. However, when you take an X-ray, the renal stone may be confused by something else which is not a stone but something else. And what is that? Number one, I will tell you, is that this may be a calcified lymph node, it may be a phlebolith, there may be a calcified shadow in the vessel or vein. Then tip of the lumbar vertebra may be ossified. That may also cause a doubt of a stone of this thing, kidney or ureteric origin. Then there may be a person has taken something orally and is not prepared. There may be something in the intestinal tract which is what this thing which is radio opaque and creates a confusion about the stone. And there are a few other things also which may be confused with the renal stones. I've already told you about about phlebolids, foreign bodies, ossified rib, and there may be some calcified shadow in the kidney because of tuberculosis. All right. So X-ray abdomen will just is a basic investigation which will tell you about a radio-opaque shadow in the kidney, in the ureter and the bladder. The next logical investigation which comes to our mind is these days patients themselves will seek and advise the doctor himself that he would like to undergo ultrasound because he has got a pain. He doesn't know the pain is of renal origin or something like that. So ultrasound will demonstrate. It's very easy because ultrasound is a good investigation for kidney, and ultrasound is done from posteriorly. That will exclude the stone, a renal stone, from a stone in the gallbladder. If there in a radio X-ray of the abdomen you find a radio opaque shadow, you can exclude whether this is a stone from the gallbladder or is a calcified mesenteric lymph node by asking for a lateral view of the X-ray. A lateral view of the X-ray, if the stone is anterior to the vertebral column or is superimposed on the vertebral column, this may be either a mesenteric lymph node anteriorly. Mesenteric lymph node will be anterior to the vertebra. Gallbladder is an intraperitoneal structure, so therefore, and kidneys are retroperitoneal structure, so therefore kidneys are behind, posterior to the vertebral column. You take a lateral view. So that way, of course, ultrasound is a very good investigation. It will tell you what the size of the stone. It will tell you an enlargement of the kidney. It will also tell you there is a cyst. It is a simple cyst or it is a complex cyst, but a solid element inside which is suggestive of malignancy. The ultrasound will also clearly see the pathology besides the kidney, liver, spleen, uterus. It is not a very good investigation for ureter because ureter is the lumen is it is not a solid organ as compared to the kidney, and also when you do the ureteric study, the gas and the fat in the abdomen interferes in its visualization. Then ultrasound will also tell you about the state and size of the prostate gland, whether it is enlarged or it is not enlarged, is there any hypoechoic shadow. And the better investigation for the prostatic gland is transrectal ultrasound. What I said is transrectal ultrasound, which may show that prostate is enlarged because elderly persons, the more than 60 years, 70 years, high percentage of them, even after 8 years, more than 80% may have carcinoma of the prostate. When a person has got a carcinoma of the prostate and is confined, there are various stages of carcinoma of the prostate which I would not like to discuss now. You will find transrectal ultrasound is a better investigation. You find the hypoechoic shadow, and to diagnose it under the guidance of ultrasound, you do the FNAC at multiple places, 10 places. If a person is suspected to have carcinoma of the prostate, elderly person will have a pain in the perineum, you may have hematuria, there will be mets in the bone, and you will have bony pain also. And it is difficult, all the symptoms of enlarged prostate like difficulty in passing urine and frequency and things like that. PSA is raised. So therefore, in such situations, you can ascertain, yes, there is something wrong, and ultrasound is a very good investigation. That it will tell you about the hypoechoic shadow, and you can take multiple fine needle aspiration cytology, which is called FNAC, fine needle aspiration cytology, to ascertain the histopathological diagnosis. Anyway, well, let's proceed ahead for the investigation of a urinary case. There are very simple investigation which should occur to your mind. that is routine urine examination. What did I say? The urine examination, the routine. In this, what you can find is there's so many information, so much information you get by doing a urine routine examination, and that is a person may be diabetic, and most of the diabetics are asymptomatic. They don't know they have diabetes, so you'll find sugar in the urine. You will find proteins. You will find casts in the urine, glomerulonephritis. So therefore, you may find what you call even this thing. You may diagnose the hepatitis also. You find urobilinogen and things like that. Then specific gravity in the urine, whether it's it is concentrating the urine properly or not. Then urine routine examination tells you, in elderly people in particular, you may do the urodynamic studies. What did I say? Urodynamic studies, which assesses the flow rate, how is the flow and how much flow is there, and what are the post-voiding residue in urine. A person has gone to pass urine, and you do the ultrasound, you find the still urine is left behind. This is called post-voiding residual urine, and post-voiding residual urine, which is more than 100 ml, is significant. And you can assess the flow rate also. Flow rate. What is the flow rate of the urine? If a person passes a urine, say of 150 ml minimum, and if you assess the flow rate is less than 10 ml per second, that means there is some kind of obstruction, obstructive uropathy. So therefore, surgical intervention may be required. Then if the flow rate is between 10 to 15 ml per second, then what we call is that person has got prostatic enlargement, and for prostatic enlargement you have done the investigation. Digital rectal examination is a must. The finger examination, in which you assess the enlargement of the prostate with the grade 1, grade 2, grade 3, its consistency, how is the sulcus, is there any nodule, any ulceration or some kind of thing you feel. So therefore this person qualifies for uroflow studies also. And the flow rate in a person who got urinary symptoms is more than 15 ml per second, then you can do watchful waiting. Watchful waiting. You can watch the patient. Otherwise, a person having less than 10 ml flow of urine per second may require surgery. 10 to 15 ml may be treated with a medicine, and more than 30 ml per second means he can undergo watchful waiting. So the urodynamic studies. Now what is the next investigation? Is a CT. CT will accurately tell you the location of the stone in the kidney, the bladder, and even in the ureter, in good hands, experienced hands. CT is a very good investigation. CT, contrastnal CT, a person who is suspected to have carcinoma of kidney. It will tell you about the size. It will also tell you of involvement of the regional lymph nodes in the hilum of the kidney. CT will also tell you a person who has got renal cell carcinoma or carcinoma of the kidney, involvement of the renal vein and inferior vena cava, because the line of treatment will change. The next investigation you can do the MRI also. The other investigation that I just want to mention and come to the point, the renal stones, is the endoscopy. You can visualize the urethra, you can visualize the urinary bladder, you can visualize the ureter through an endoscope or cystoscope, ureteroscope, and see the pathology inside. Sometimes there will be ureteric obstruction, so therefore a person may not be able to find out the structure and pathological events occurring in the upper urinary tract. Endoscopy is one of them. Ureteroscopy, cystoscopy, ureteroscopy, and things like that. And I also mentioned about you right in the beginning that one of the investigation, intravenous urography, which is a very good investigation, which is a static investigation, but it tells you about the structure and function of the kidney. and any obstruction down below into the ureter. It can also, you can do the ascending urethrogram also. That means you put a contrast, which is containing the organic chemicals which are mixed, which are tagged with the iodine compounds, which are radiopaque. So it will tell you about obstruction of the urethra, the site of obstruction in urethra. You can do intravenous urography. You inject the contrast into the vein, which goes into circulation, is excreted from the kidney. Iodine is not absorbed. So therefore, right from beginning, when you find the kidney shadows, which is called a renal shadow, nephrographic shadow, the kidneys are visualized within just 5 minutes. Then you take serial X-rays. When you injected a dye for intravenous urography, you are taking X-rays, 5 minutes, 10 minutes, 15 minutes, 25 minutes, 30 minutes. If there is a delayed excretion, it may spill over to the next day also. So intravenous urography is a very good investigation to locate, as I will show you in one of the snaps, that a radiolucent shadow is there. Besides that, if you want to see, suppose both the kidneys are involved, whether both the kidneys may be damaged or one kidney may be damaged because of pyelonephritis or pyelonephrosis or whatever it is. So therefore, you want to assess the renal function of individual kidney, which is not only academically but otherwise also helpful. It will help you out in medical legal aspects also. That is DTPA scan. I will not go into MAG3 scan or something like that, but I will talk to you about diethylene, diethylene, triamine, pentacetic acid scan, DTPA scan. Here what we do is, there is a radioactive substance, technetium-99, which is tagged to this substance, and this, you have a gamma camera. This will find out the relative function of each kidney. If the kidney function is less than 11% and is infected kidney, it is a xanthelomatous glomerulonephritis. A person is, he can undertake nephrectomy, a kidney which is not functioning, but for that you have to have this scan. Then of course, the another investigation is urine culture. That if there is any infection, you're suspecting any infection in the urine, you ask for a urine culture before you start the antibiotics. Now let's come to the renal stones. Renal stones, I am talking about renal stones. In between, I must tell you one thing. I'll continue with the renal stones, but I would also like to mention and tell you that we are a noisy people. One should be positive, but there are certain things you have to live with, loudspeaker noise and things like that. The place I'm living is generally very peaceful. I don't know. This loudspeaker noise is intolerable. It spoils your mood. It disturbs peace. It is bad for the ears, and it takes away so many things. You cannot study. You cannot sleep. And I am trying to talk to you, and my attention has been diverted by somebody. Generally, it doesn't happen in a place like this, which is secluded. I don't know. I think these are the servants' quarters and things like that. Anyway, I'm coming back to renal stones. Peace is very important, and real peace exists where there are no human beings. Human beings are the most notorious for causing all kinds of human problems. Really, I'm telling you, much more than the animals, wild animals. We are worse than the wild animals. Just because it's a wild animal, and all kind of loudspeaker, the traffic and things like that, the horn business, and anyway, I'm coming back to the point. Renal stones. Why renal stones? The cause of renal stones may be metabolic. Recurrent stones, bar, multiple stones and things like that. Person may be suffering from hyperparathyroidism. The thyroid gland, there are 4 parathyroid glands here in this region. So if it is over-functioning, person may land up with renal stone, number one. Number two, there are other causes like infection. Infection may occur because of anything. Infection may occur because of stasis, with obstruction to the outflow of urine because of renal stones or malignancy or prostatic enlargement. They may cause renal stones, right? Then there are dietary factors also. Persons who are taking less vitamin A. The dietary factors of renal stones, a person who is taking less amount of vitamin A, there is desquamation of the epithelium, and this acts as a nidus for stone formation. Then of course a person who is taking less amount of fluids, person living in a hot and humid climate, hot climates where there is a loss of fluids, dehydration may cause renal stones. A person who is taking too much of tomato and red meat and fish and things like that, they are all persons. Then of course there are certain metabolic factors in addition to what I have already said. And then of course persons who are having less excretion of citrate. The normal excretion of citrate in the urine should be between 300 to 900 milligrams in 24 hours. If it is less, person is likely to have stones. I'll quickly go through what are the types of stones. The first and foremost are the calcium oxalate stones, which are hard stones, which may be colored also because of they damage the urothelium, which causes microscopic hematuria and the deposition of degradation products of the RBCs. So therefore they get colored. And the calcium oxalate stones are radio opaque. You can easily identify in X-ray. They cause a shadow because they absorb the X-ray radiations. These stones are notorious, but it's much better to have, if you are asked which stone you like to have, is calcium oxalate stones, because they present early, which cause pain because of the spines on it, which damages the urothelium. Then there are triple phosphate stones, calcium, magnesium and ammonium. They are called triple phosphate stones, and these stones are notorious. They'll be lying silent, they won't give you any pain. They're lying there and keep on enlarging. A person doesn't know, he comes to know in late life, But both the kidneys are involved, and they involve the pelvis of the kidney. I've already shown you the snap of the pelvis. And this stone extends to the entire pelvis, all the three calyces, and even the mild callus. So it becomes something like a staghorn. This is called staghorn calculus, triple phosphate stones. The next stones are, this uric acid stone. Watchful. See the serum uric acid and increased excretion of uric acid in the urine. Uric acid stones. Then besides uric acid stones, you have xanthine and cystine stones also. These are the types of stones. Anyway, now let's come down quickly. Let's revise. Anatomy I've already told you. The kidneys 11 centimeters long, 6 centimeters wide, 3 centimeters thick. It has a capsule, it's surrounded by gyratosis fascia. It has a cortex, it has got a medulla, it has got an excretory function, it has got endocrine function, renin and erythropoietin. Okay. Then I have already told you that anterior-most structure in the hilum of the kidney is the vein. Then comes the artery, and behind artery is the pelvis. So therefore, we must approach kidney in open surgery from posteriorly without damaging the renal vein and renal artery in case we approach it anteriorly. I used to do surgery for adrenal tumors by adrenal anterior approach, obviously, because there should be renal handling. Anyway, besides the point. Then investigation I've already told you. Now let's go for the treatment. Treatment for kidney stone is first tell the person that please drink a lot of fluids orally, because if there is a small stone, say 5 mm stone, is a small caliber stone, so it is likely to pass off, right? Try conservative treatment, expectant treatment for a stone which is 5 mm. The small stones are likely to wash off. If a person is advised, take plenty of fluids orally, 2 liters, 3 liters, 4 liters, something like that, and improve the dietary restriction. Investigating, so what is the serum calcium levels, If one in the multiple stone, you have to ask for serum calcium levels also, serum phosphate levels also. See in the, and there's increased excretion of calcium in disease like hyperparathyroidism. So expected treatment, given dietary advice, please be take more of fluids and avoid, like foods which have got more of oxalate, like plums, apricots, red meat, fish, eggs, etc. Then if the stone is a larger one, what you can do is, number one, if there are multiple stones in the kidney and a large stone, the Staghorn calculus, the experts opine anything is possible. There's an open surgery to remove the stone, which is called nephrolithotomy. What is it called? Nephrolithotomy. And in patient is approached from the posterior route. That is, I think, out of context as far as you people are concerned. Nephrolithotomy. An incision in case the stones are extending right up to cortex. There is a Brodel's line, which is a line 5 mm behind the most convex border of the kidney, and is a bloodless. In case you have multiple large stones, you may have to open the kidney like a book, apply clamps on the renal pedicle to avoid bleeding, and open the kidney and remove all the stones. We have done it for large stones. This is called open nephrectomy. The other approach to remove stones is percutaneous nephrorectomy, which is called PCNL. What is it called? PCNL. What is it called? PCNL, percutaneous nephrolithotomy. That means it is a minimally invasive surgery. You do not give a huge big incision right from loin to loin or something like that, lumbar region, the old thing, but still it recurrence of the stones, where the kidneys. You are somebody who operated on the kidney stone. I have done it. And again there is stone formation. Kidneys very much adherent. The anatomy is distorted. So therefore you may have to resort to open nephrolithotomy. The other approach for kidney stone is percutaneous nephrolithotomy. You put a guide wire, you put a sheet, and the nephroscope goes inside, and then the stone is crushed and is sucked out. Okay. If the stone is less than 2 cm in size, you can also do extracorporeal short wave lithotripsy, ESWL. What did I say? ESWL. ESWL. E, extra corporeal short wave lithotripsy, where you pass strong ultrasound waves, and the stone is less than 2 cm, and they are not multiple stones. The stone will get fragmented, broken up, and will be washed off. And these stones, multiple stones, small stones, when they are being broken up by extracorporeal short wave lithotripsy, they may block the ureter. And once the ureter is blocked, there will be an obstruction. Patient will be cursing the urologist, surgeon, whosoever it is, that I had undergone surgery, and this is the problem. I got this thing, agony. Patient. The whole idea of doing surgery is to relieve the patient of his suffering completely. It should not happen. So therefore, before you do extracorporeal short wave lithotripsy, when the stones are broken up, inside you find bacteria. They are released. Person may go into septicemia. He has come for surgery to the hospital walking, and then he lands up in problem and ICU, things like that. Intolerable, impossible to satisfy the attendants and the patients. How do we show our face to the person who has got a 1.5 cm stone and undergone ESWL or PCN or whatever it is, and lands up in the complication? So therefore, you put a stent, which is called DJ stent. That, God forbid, in case the ureter is obstructed, you put a stent inside through the urethra, through the bladder, through the ureteric orifice, which connects it with the, it is called internal diversion of the urine also, and goes into the renal pelvis. So stones are getting fragmented. Okay, they'll keep on. Once the stones are fragmented, in any case they have to come out for a period of time, small stones. But if you put a stent inside, the ureter will not be obstructed. Otherwise, subsequently, that kind of thing, you might have to put a nephrostomy tube and divert the urine externally, external urinary diversion. So therefore, when you are doing ESWL, You stent, do the stenting, and you give him antibiotics. Once the bacteria are released, they may cause septicemia. So this is ESWL. Then what else we do? We can also remove the stone. Some people have seen removing stone, they go through small stone and retrieving. I'm not going to talk to you about ureteric stones or things like that. They can be removed endoscopically. Okay. Then of course, as far as stones are concerned, one thing is very important to decide when a person is having stones on the both sides, which side to operate first. That is a priority, because people have done mistakes. Guidelines are very clear. It is the surgeon who has to decide. The kidney which is functioning better, firstly we have to retrieve, because suppose there are stones on both sides, both the kidneys have got stones, and the function is compromised. Which side to operate first? We should operate on that side first, which shows a better kidney function, so that the stone is removed and kidney comes back to normal. And then we tackle the kidney which is not functioning well. But if we operate on a kidney which is not functioning well first, that kidney, if God forbid something wrong happens, that is gone. And now we come to the other kidney which is showing some function, and we operate on that side, that is also not, the patient had it, goes into problems. Patient may require dialysis or things like that. It has happened. The patient has spent a lot of money. So therefore, or the first thing is you operate on a side which is a better functioning kidney, number one, and the site which is giving him pain, because he has come to you for relief of pain. So you operate on a, unless one kidney is totally, one kidney has got renal stone, other has got a pyelonephrosis, he has got a septicemia. So which kidney will operate? Obviously you have to eliminate infection first. So pyelonephrotic kidney, use this kidney that has to be removed first. Pyelonephrosis invariably, because of the stone stuck in the pelvis of the kidney, there is the hydronephrosis, obstruction of the outflow of urine, and you get infected. Now there is a pyelonephrotic, is the bag of pus. It becomes a very tricky situation to which one to. So therefore you have to somehow eliminate infection first. Make a person normal. Kidney function test. What are the kidney function tests? Besides your basic investigation is blood urea, serum creatinine, they have to be done. In the elderly people, even if you have a normal blood urea and serum creatinine, the kidney function, an elderly person is working on 50% sometimes. So blood urea creatinine will be rising when the 70% of the kidney function is lost. So therefore be careful. You have to ask for a urea and creatinine. Until the time you stabilize the kidney function test, you will resort to surgery. Then it's very difficult to rescue the patient. It happens. You operate on a person who is jaundice, number one, and the person who is resolving a renal failure, and of course you have to tackle the problem. Firstly, normalize this kidney function. Whether you want to normalize with some renal replacement devices, whether dialysis or something like that, control infection, remove pus, you have a external drainage to the percutaneous drainage. So what I mean to say is that a sound judgment is very important, and don't rush and hurry up for surgery. Give time. There's nothing wrong in patient, making a patient fit for surgery before you put a knife. And once you put a knife and operate on a person whose renal function is compromised, we had it. Anyway, and follow up, you can see that I want to tell you, always unhesitatingly, there's nothing to fear about if you are truthful and honest. Once you have moved a stone and you're still doubtful that I might have left something inside, do not hesitate to follow up immediately after surgery and after surgery. Do an X-ray. It is a matter of inconvenience and embarrassment. Please check back that the same sitting before he goes on discharge, ensure that his kidneys are clear. Clearance is total. You cannot send a person home with a renal stone. You could not remove it and send him home. That amounts to a little bit of your disinformation. and you don't do the X-ray, and he comes back after 2 months, 6 months, 4 months, 3 months, again he comes with the pain and goes to somebody else and do his X-ray and ultrasound and CT to find your stone remains the same as it was before. Where do we go? So therefore, my dear friends, in our practice there is absolutely no scope for misleading a person, a patient. No, not at all. If unfortunately it happens, you're not a very good surgeon and things like that. If happens something is wrong, you're not sure, do an X-ray and tell clearly and that this thing has the stone is still left inside. We'll do this thing URS. We'll do the URS and remove it endoscopically. Nothing happens, you can consult your colleagues. Call them there and then itself. In our profession, teamwork is a must, but unfortunately we've got a system. In big large hospitals, you've got one surgeon or one this thing is. Medical colleges are that way. They are doing a wonderful job just because there are so many surgeons. I was reading a party with 34 surgeons, including residents. You are a consultant. I used to be called too frequently into the operation theatre. Comes so there's a problem. Yes, of course. Right? When 3-4 people join, it boosts your morale. When you've gone wrong, you're unable to do it, call senior one and go. It is a pleasure for the HOD. When I was HOD, I used to go. Yes, most welcome. So therefore, it boosts the morale. But do not. It has happened. You're working in smaller hospitals. There is one surgeon, is visiting the surgeon is the consultant surgeon. Things like that. It happens. It's the need of the hour and things like that. So therefore, if something wrong happens with a visiting consultant and you pack it off and after 4 years, 3 years, the person has got a pain and he goes to some other place, if it is the same place, it will come back to you. No problem. The patient will come back to you. It goes to other place and they find out this thing and it's a very embarrassing situation. Anyway, coming back to this thing, ask the patient to be very disciplined. Control is any metabolic disorder like diabetes and things like that. Take plenty of fluids orally, have frequent follow-up, note down his number, make a record of it. And that's the end of it. Thank you very much. I hope you go back. You go back and read what I've talked to. If you go back, you listen to me, and you have not already read it, you're supposed to read it, what syllabus I've been given and things like that to talk to you. It will be something very good for all of us. And thank you very much.